Okay, so what is wrong with the people in these two photographs? Answer at the end. The selective tissue tension examination was developed by James Syriax, MD, in England back in the Dark Ages, in the 1950s or so, but it remains the most logical, systemic and effective clinical exam process around. Part of that examination are the contractile tests, and that is what will be under discussion in this webinar. As with the rest of the selective tissue tension exam, the aim is to isolate the tissue of interest from the other tissues and then stress it by making it perform its function in this splendid isolation, or at least as much isolation as possible. I had Syriax as a teacher, and before you ask, it was a good deal later than the 1950s, so I can make this comment from experience. While he was an excellent teacher and clinician, he tended to make everything black and white and not bringing in the grey shades. While this does make learning easier, it certainly makes teaching easier, it is up to the student then to identify the grey bits and deal with them in their splendid isolation. For example, passive movements were taught as isolating the inert tissues such as ligaments and joints without bringing up the vexing quality of muscles and tendons being stretched and producing pain if they were in trouble. While I am certain that Syriax knew this, he never really dealt with it when teaching us. We will deal with this issue on the following slides. For Syriax, the contractile tests consisted of following the second part of his rule, which stated that pain with active range of motion in one direction and pain with passive range of motion in the opposite direction signal a contractile tissue dysfunction. In this case, the passive movement is stretching the muscle tendon and the active movement is causing pain due to its contraction. In addition to this, he, of course, included pain on isometric contraction in the diagnosis. The problems with this rule will be pointed out later. So, he basically tested contractile tissues with both stretch and isometric testing in the neutral position to remove the stress from the joint. I would add to these two tests. Palpation can be used as a highly sensitive test provided you can palpate the entire muscle tendon unit. It is difficult to see how you can have a contractile pathology and it not be tended to palpation. The positive results from this testing is pain on palpation, stretching and/or contraction, weakness and painful weakness. As I've already stated, Syriax tended to be very black and white in his teaching. Everything was tendonitis or muscle tear, and this was understandable, as the greyness that is tendinosis didn't have much, if any, presence back then, and this alters the picture considerably when it is considered. If he adhered rigidly to his own rules, including the passive movement being positive in one direction with active in the opposite, and always testing in neutral and only using palpation as a final test, then he would never have diagnosed a non-inflamed tendinopathy, and everything he did find would have been a tendonitis or a muscle tear. Or it could have been his wanting to get principles across and not get bogged down with an at the time unproven pathology. I tend to think the former. So interpretation of the results is an absolute necessity. For example, while painless weakness may be caused by a grade 3 tear, it may also be caused by neurophysiological or neurological conditions. And as you will see on the next slide, other pathologies can cause a positive contractile test. As a lead-in to the false positives found with isometric testing, let's look at what happens to the bone and joint when the muscle is contracted isometrically. An isometric contraction may not significantly move the joint, but it can stress it. Syriax advocated, in fact required, that some isometrics be carried out in the relaxed position of the muscle, and that usually coincides with the rest or least packed position of the joint. But stresses are still felt by the joint and the bone, and additionally the muscle tendon can be bowstring down to the bone, so if there is an underlying inflamed bursa, this will cause pain. The three diagrams above show how this works. The stretched position of the muscle causes a compression force through the bone and the joint and is more liable to be compressed down against any underlying painful bursa. While in the rest position, the force felt by the bone and the joint is shear. So if the joint is painful enough, such as with severe arthritis, both forces may cause pain, and of course, if there is a fracture nearby, it will be stressed and made painful by this isometric contraction. Causes of false positives tend to be clustered around the more acute presentation and include arthritis, articular and extra-articular fractures, bursitis, when it is compressed by the overlying muscle, particularly when that muscle is on stretch, altered sensations such as those listed above, most of which are perceived as pain and are caused by various neurophysiological and neurological conditions. These causes of false positives are generally as severe in pathology or worse than the putative tendinopathy. However, the situation seems worse than it is because we are looking at these tests in isolation from other information that the subjective and objective examinations will throw up. For example, confusing a fracture with a tendinitis is unlikely when the history tells you that there was significant trauma accompanied by severe and immediate pain. A tendinitis can be caused by trauma, but the pain from the inflammation of the tendon is usually delayed in its severity. But a muscle rupture and a fracture can appear similar, so other factors such as which structures are tender on palpation have to come into play. While Cyriax was adamant that isometric tests should be done in neutral and palpation be the last test carried out, I must on practical grounds disagree. If I palpate the entire length of the muscle tendon and there is no tenderness, is there any point in carrying out the other contractile tests? Additionally, some tendinoses can be quite mild and are not painful when stressed in neutral. So I would suggest that you tailor the test to the putative hypothesis generated from the subjective examination. If you believe that a tendinitis or grade 2 tear is present, then test in neutral. If not, test in the stretched position. Sometimes a maximum contraction in the stretched position is necessary to elicit pain and sometimes not. Which you do depends on your hypothesis, but in general a maximum contraction while stretched will put maximum stress on the tissue, while a minimum contraction in neutral will put the least. So the former is more sensitive and the latter more specific. The exception to this is when the stretched position so disadvantages the muscle that it cannot generate a strong enough force. From your subjective exam, you decide that a tendinopathy is present, and you have a good idea of whether you are dealing with an itis or an osis, and you will get more information from the exam itself. This foreknowledge will guide you on how to test. So let's assume your H1 is tendinitis. The first test will be to palpate the muscle tendon unit and decide first that the tendon is involved and that it is exquisitely tender. If there is no tenderness, then H1 must be incorrect and you need to formulate H2 and test that. If palpation is tender, then the isometric test will be done in the neutral position with an initial minimum contraction and progressing the force as necessary. If it is a tendinitis, then not much resistance will be required. If that is positive, then your H1 is your working diagnosis. If the test is negative, then H1 again failed and your palpation needs to be done with more care, taking in surface anatomy and consideration given to overlying bursae. Again, you need to generate H2 using current information. If a tendinosis is your H1 and palpation is moderately positive, then the isometric test can be done in the stretched position, and if positive, H1 is proven. If negative, repeat the maximum contraction in neutral, and if this is positive, then H1 is again proven, and the false negative may have been down to the muscle not being unable to generate sufficient force because of its positioning. If both are negative, then H2 is required, as your surface anatomy has failed you. Although this is more excusable, as you may need deep palpation and went through another tender tissue, nonetheless, layer palpation is a requirement. As you could have guessed, if you've seen my previous webinars, I have a few problems with using the selective tissue tension examination in its entirety as a routine diagnostic examination. For me, tests should be used to prove or disprove a hypothesis in the same way that specific imaging should be used with specific pathologies. In this case, the examiner would already not only have a contractile pathology in mind from the subjective examination, but also whether or not it is a tendinosis, tendinitis, or a muscle tear. If this is done, then many of the false positives would not be an issue because you would be investigating a different pathology and not use contractile tests in the first place. In short, I think that the individual tests of the selective tissue tension examination, for the most part, do as expected of them, but the process of the entire examination being used is misguided. This is quite hard for me to say, as I am not only a great admirer of Cyriax, but for years used examination as he required. Once I had managed enough quality experience, I could use pattern recognition and use only those tests that I thought specific to the condition. The complete examination process does have its value though, but not as a diagnostic test or examination, but one that can reduce or even correct bias and error. Okay, so let's have a look at an example of a patient. We have a 25-year-old man played in the community baseball league over 2 days. Towards the end of the second day, he started to feel an ache in front of his elbow that was worse the next morning and severe by that evening. So how do we go about dealing with this? Well, we look at where the pain is. It's in front of the elbow. We look at what he's been doing, which is a lot of effort over that period. And we can either think it's a joint problem or that it is a contractile problem. Probably think about the joint as the easiest, so what we try to do is passive movements. And we bend the elbow up and we straighten it out. And what we find is flexion is fine, although it may be a bit sore at right at the extreme, but extension is limited, probably by 20 or 30 degrees, and you're likely to start feeling spasm at that point. So we know it's not a joint problem simply because he's got good range in one movement and bad in the other. So this is not going to be an arthritis, but we can check on that by looking at the glides. If it's gliding fine, then we don't really have a joint problem. So we next move to H2, which will be a contractile tissue problem. Now the temptation here is to say that this is a biceps tendinitis, and you are making the hypothesis way in advance of the information you've got. What you can say is that because extension is painful and limited, it's probably stretching a flexor. So we can hypothesize that we have a flexor tendinopathy. Given the fact that the range of motion is limited and the pain is severe, it's probably a flexor tendinitis. So we'll go in with that as our H1. We'll palpate the flexor muscles as well as we can. Some of these are pretty deep, but we'll palpate the flexors as much as we can. The muscles are fine, and we find that the biceps tendon is extremely tender. The whole area in front of the elbow is actually tender, but the biceps tendon is spectacularly tender. So our hypothesis is strengthened. We can then think about doing the isometric test. Now, because we are considering this as a tendinitis, we'll do this in the neutral position of the elbow, so about 70 degrees shy of full extension, or 110 degrees. So what we'll find if this is a tendinitis is that resisted extension on the patient's part. So as we push this into extension, the patient pushes against it in flexion, and it doesn't take much and we get severe pain and weakness. The muscle just gives way. So our hypothesis is very much strengthened. Now, is this a biceps tendon? Well, the biceps tendon is tender, but we should also check supination. Now, supination can be quite difficult to do without the elbow flexing at the same time. So you've got to take some care with this. We'll do it in neutral, and so it's in pretty much a mid position of the forearm, maybe a little bit of pronation somewhere in there. And then we will try to produce pronation as the patient resists by doing supination, and we find that that is painful as well. Possibly not as painful as flexion is, but certainly very painful and possibly weak. We basically at this point have a working diagnosis. Now, this is not taking into account other pathologies, but we do know that the joint is probably okay. Whether there's other pathologies in it, such as bursitis and stuff, we won't know. But this is our working diagnosis now. So you need a process, not necessarily the one I've just given you, but you need a process for dealing with each of these pathologies as they crop up. And it's really important that you make the hypothesis as soon as you get enough information to, which is usually where is the pain. So I hope this helps, and good luck with the rest of your studies. Bye. Both of the upper pictures have the same condition. This is an abdominal diastasis where the linea alba actually splits, and is what you can see. So in the first picture, you can see the transverse abdominal poking through, and on the other one you can see the separation of those muscles, the upper muscles in particular. This is not a hernia. A hernia is seen on the lower picture, and this is it actually coming through the abdominal wall. This is viscera. Okay, so I hope this was enjoyable to you, and you got in some information you may not have had before. So again, this photograph is taken from my sun deck overlooking Lake Chapala at sunset. This is last Christmas time. Not bad here. So I will talk to you again soon. Take care, everybody. Bye.